Okay, thank you to all our panelists. That was terrific. Covered a lot of ground, and we're now going to open it up for our panel discussion. I've already received some questions, but I encourage you to write questions and send them down to the front. We'll have about 20 minutes to discuss. So I'm going to start with a question that I think really has relevance to the whole day, and we haven't discussed it very much. Policies and guidelines are often put forth with the best intent to improve public health, but often lose sight of the impact on participants. To what extent are those who use the programs brought into the discussion for policy change? And I think a lot of what we talked about today has been terrific in terms of the evidence base informing what we should be doing, but we all know recipients sometimes aren't aware of the evidence, and the way it's impacting them can be negative or unintended. So do you have any experiences with either federal, state, or local policies and programs where you did formative research, focus groups, interviews, really tried to get input from those who would be impacted by the policies or programs?
Well, I guess I was going to mention, one of our largest community programs, the REACH program, which is reducing racial ethnic approaches in communities, really is based on a community coalition model, really, CVPA, community-based participatory approach. And I think, with that comes the balance of understanding of what we as scientists think are evidence-based approaches, and really the pragmatic feasibility of where community members think there are problems. And so I think that's where some of the work we've done around drinking water really comes in, because I think right now, especially, we're looking at these perceptions related to the safety of water. And a lot of folks don't know when they purchase bottled water that water is coming from municipal sources. It just maybe has one extra filtration that a company is putting forth. And so folks are using their discretionary funding that could be used for fruits and vegetables and other healthy foods because of these perceptions. So I think that's a particular area in beverages right now where community input and community awareness is really important, because if not, we have studies where we've looked at perceptions of tap water safety, and what we found is the Hispanic families had a higher distrust of tap water in the U.S. This was done in the early, around 2010, 2011. And that was associated with a higher SSB intake. So we really had some work to do related to both bringing up the awareness of the healthy opportunities in the home and decreasing that. I'll turn it over to Natasha.
Yeah, I think from the perspective of the child care setting, it's critical that the child care providers themselves are part of the conversation, because there are implementation barriers that people who are coming up with policy ideas might not be aware of, and this is especially true when it comes to family child care settings. And I think there's a phenomenal national conversation related to nutrition in child care settings that is having a holistic approach. The BUILD Initiative, NMORS, the National Association of Family Child Care Providers are all getting together to think strategically, as well as many others, on how we can improve the nutrition in a variety of settings, including family child care, without actually creating more barriers to child care itself. There is a child care crisis in many communities, and access is a phenomenal barrier. And so just thinking about quality and how that might impact access is a really important conversation before public health advocates go in and try and add more requirements in the regulation for licensing.
Great. Thank you. That leads to another question about evaluation. I wondered if any of you could give some examples of evaluations that have been done on effectiveness, particularly around the dissemination of materials to communicate selecting healthier foods and beverages for children overall in these settings you talked about, and particularly for low-income children living in rural, underserved areas. So just any studies you can cite or effectiveness trials that have been done.
I can speak to evaluation that was done of the child care regulation that was adopted in New York City. And in that instance, there was an analysis of obesity rates in impacted areas, and there was evidence that obesity rates did decline among early children, or early age children. And there was actually a greater impact on the neighborhoods most at risk. I think in terms of the communications materials, we do always do focus group work in terms of developing our communication materials. I know that in this area, it's generally, there are a lot of challenges around evaluation, particularly because of the difficulty of assessing, of parsing out what's really making an impact. Is it policy or specific education efforts, or is it changing social norms, as well as the difficulty of part of looking at, you can look at health behaviors over the short term, but tracking outcomes is obviously much more challenging.
Mm-hmm. And I would say that on the federal side, there have been a number of evaluations of the new WIC package, which have shown that among low-income kids who are the target for WIC, there have been improvements in eating with respect to diet. There have been declines in obesity, and so that change happened most distantly compared to sort of national school options. So we're waiting on those evaluations to come. But WIC is a very good example of where there are good evaluations showing positive progress.
Great, thank you. So this question is for you, Sarah. So you talked about within CACFP that SSBs can be served but not reimbursed. Mm-hmm. Do you think CACFP should be changed so that no SSBs can be served at all? And if you believe it should be changed to indicate that, how could that be monitored?
So do I think that SSB should not be served within CACFP? I think from a public health perspective, certainly, having SSBs in front of children, they're just attractive and they're tasty. And if you've had them, you're probably going to want more of them. And so just reducing that exposure among young children who, if they haven't had it, they wouldn't want it, but when they start to have it, they want it more, is a good thing. To the question of how you actually make that happen, I think it becomes much, much trickier, to the point that Natasha made about there are federal policies that come down, but there's a lot of variation at the state and local level. One of the things that fascinated me last year, I served as a White House fellow with Undersecretary Concanon at USDA, is even with federal policies, how much variation exists in different parts of the country. And that certainly is accelerated when you think about all the differences in localities. So I think, big picture, should they be allowed? No. But the nuts and bolts and the mechanics of making that happen is probably quite tricky.
Go ahead.
Well, Chris, I think we also don't know the question of what's actually happening in practice. So we don't have a 50-state ECE surveillance system like we do for school, like SHIPs and profiles. I have a slide in the back of my deck there that we think we've seen about 9 states that have done either census or sampling. You know, California, Susie Nanny's work in Minnesota and Wisconsin. But CDC we're trying to pilot and actually, you know, just a 2-state pilot to show the feasibility of doing this in each state. But there's really no resources to actually answer the question of whether, you know, sodas are being served or offered, or then is there a difference between CACFP and non-CACFP reimbursements?
Great, thank you. Okay, we're going to switch gears a little bit. So this question is about providing incentives or strategies for school districts to reverse the trend of being dependent upon soda companies for funding. Particularly a concern for rural, frontier, underserved communities with limited resources that could be enticed to perhaps accept some funding that would then require them, maybe subtly, maybe overtly, to advertise. I know it's been an issue, and I've studied it within sports leagues, within out-of-school time programs. We've tried really hard to limit or eliminate this in the school level, but I think there's still some of it that's going on. So are there any incentives or strategies, particularly within school districts, to stop this from happening? Do you want to start, Heidi?
I was actually just making a note. I think we need to go back and look at the latest data we have related to that. I'm not sure we have good enough questions right now in our profile survey at CDC, but yeah, I think we need to look at that. I mean, when we've looked at some of the marketing data within schools, you know, where it seemed that there were actually kind of the worst was right above Title I schools. And so it seemed like maybe the lower resource were finding grant opportunities in other areas, but it was the schools just right above that where that maybe those were the ones that were taking incentives. So I think we can go back and look at that data, but that just shows that, you know, there's a kind of maybe a U-shaped curve related to resources in some of these districts.
Yeah. Does anyone else have a comment or have experience with seeing that play out or strategies to limit it?
I think I would just say it's definitely a significant issue more generally, and it's that even your question goes to the importance of really recognizing the various forms that marketing and advertising takes and putting it right into the conversation that this kind of sponsorship is really another form of marketing, and we can talk about it as marketing to kids is an important starting point. We have been able to successfully eliminate sugary drinks from vending machines in New York City. and making that a policy priority and framing it as a high priority in that way, I think has helped to have that kind of success. Similarly, in our vending standards, we require that sugary drinks aren't part of what's being promoted in the vending machine itself, so it should be water or a low-calorie drink. So I think that there are certainly policy opportunities there, but the important first step is really having that conversation as a type of marketing to kids.
Great.
And just to add on, I guess with Smart Snacks and with the Healthy Hunger Free Kids Act related to the types of foods that could be marketed in the school setting, because of those nutrition standards for the healthier foods, I think we just need to look and see the whole surround sound of the campus, right, and make sure that we're not losing the billboards versus what we are seeing inside the school. So we do need to maintain that 2010, regs so that we can keep that marketing where it is.
Okay, we're going to talk a little bit about waivers, and I'm not sure any of you can answer this, but you may be able to, Kim. What was the justification USDA provided for rejecting the 2010 New York SNAP waiver request? And then I have a follow-up question about waivers.
So I wasn't with the health department at that time, but I was working in the mayor's office, and going back to my memory, complexity was certainly part of it, that it would be too complicated to implement. I think that was one of the major concerns that was shared with us.
Okay.
And there have been several states that have come forward and requested waivers of USDA to restrict purchases of sugary beverages. Complexity is definitely one that comes up, as well as there are other arguments around sort of the administrative burden of having to actually change the UPC codes within the system, the ability to actually provide the technical assistance at the local level, and then is there an evaluation plan in place that can adequately document whether or not there's been an impact of that change?
Okay. And the follow-up is, have any states asked for SNAP waivers for stores in particular that have, like EBT stores that are frequently shopped in by customers that receive SNAP? Does anyone know of anything beyond what we know about New York? So any other creative waivers that have been submitted? Just people are wondering if you know about anything and why they may have been rejected.
So the best way that I can answer that question is other waivers that have been submitted have included both sugary beverages and candy. But in terms of the targeting, if it was a waiver, it would apply to the entire SNAP population. So it would apply to all stores that accept SNAP dollars. So I don't think that they could cherry pick certain stores in doing so.
Okay. Natasha, you might be able to answer this one as a start. Okay, it seems that most policies and programs working in the child care setting are focused on centers. It would seem that could widen health equity disparities, since we know that lower SES populations are more likely to use families, friends, and neighbors for childcare. Are there emerging policies and practices for states and localities to impact these populations? Creative, innovative ways that go beyond centers that serve low-income children to some degree, but may miss a large population of children?
That's a great question. I think there's a lot of attention being paid through both the research side of things as well as from an implementation side of things to try and find, because sometimes it's actually just finding those settings and then identifying what's going to work. And it's really locally specific and context specific. There's a lot of cultural and linguistic considerations from a programming perspective that need to be considered, and just from an access perspective on frontier and rural areas, what is going to really impact those populations. And so the conversation is starting, and there are, again, pretty robust conversations about the research and what is going to work in family, friend, and neighbor and family child care. I think some limitations on figuring out kind of a national strategy are that the settings are really different depending on which state you're in. And so really thinking what can happen at that local level. And some of if you're thinking about that spectrum of opportunities that Heidi put up from CDC's perspective, those facility level interventions and local programmatic interventions, sometimes through SNAP Ed, actually have had some impact in those settings.
Mm-hmm.
I think I would just add that the importance of the programming piece and the technical assistance piece was critical to the success in New York City. So there was a lot of extra effort around the implementation and technical assistance, especially to our higher need neighborhoods, and not to look at policy in isolation in this area.
And Just one more thing. Thinking about policy from not just like a regulatory perspective, but those funding streams and thinking strategically about how to actually fund and resource these providers is going to be critical if we're going to be able to actually impact the setting.
Which I guess is why the professional development online modules are so important, because they're low cost, either $0 or $5 often, and so family child care providers, as long as they do have computer access, we'll be able to have that. We're working with Nemours actually on our second pilot related to family child care homes with our Learning Collaborative model. So we're hopeful here in one of our final years on that Learning Collaborative project to have a toolkit for family care homes in the future. But it definitely is a need. It's very difficult for entities to reach all of the homes. But the good news is usually it's the one gatekeeper, the provider, who can change policy overnight because they don't have to go through bureaucracy. It's really their rules, their protocols within that home environment. So that's the good news.
And there's lots of really other great opportunities with family care providers and family friend and neighbor. I mean, they are not only the kind of the one-stop shop, so you avoid the bureaucracy, but they also are a really amazing link for parent engagement. They often have unique relationships with the parents and are embedded within the communities that we are trying to impact. And so there's a real opportunity there, and I think we should all be challenged to try and figure out ways to impact that community.
Mm-hmm. Great. Heidi, this is for you. You noted a number of guidelines, particularly around water guidelines. I think you showed 2 different resources that are available, and also around food service and public spaces. What's the evidence on use and uptake? Has there been any evaluation of the utilization of those?
Yeah, that's a great question. One of our first evaluations we actually was done here in DC in the Humphrey building, where they renovated their cafeteria and their food service, and we were able to do some just mild metrics related to procurement, sales sheets, and then what was being purchased. And so they saw an improvement in the healthier foods being offered. We're actually working on an evaluation toolkit right now because usually the vendors know what's selling well. So, if they want to look at their top 10 sellers and make sure they're not seeing drop off. But we do have on those links a number of case studies. We work with the National Public Health Institutes to look across a number of business entities to make sure that, by improving the foods, we weren't having losses through those. Mason et al. Actually has a really nice paper as well from the vending in the Chicago Parks districts, showing the improvements in sales actually with healthy vending. So I think we're building that literature, but we need to continue to keep ensuring that we're not just looking at the healthy behavior, but also considering the business enterprise and making sure that they're a partner in this with us.
Great. Okay. These are great questions. I'm going to get through most of them. I'm going to switch to an area that I work on, and I'm curious. It begins with you, Kim, but I think others could weigh in too. In New York City, have you thought about putting a policy in place to make the beverages sold with kids' meals healthier? And of course, we know nationally there are brands, chains coming on board with default options, but at a local level, have you thought about imposing something?
There was a proposal that our city council was considering some time ago about healthy meal standards, and I think that we as a department did have concerns at that time about the ability to implement that and do enforcement around it. We've also been really encouraged to see the way that fast food companies, as you referenced, have already been doing this to such a significant extent. So I think I would say it's sort of on the radar in New York City, and we're watching what happens in other places.
Mm-hmm. Great. Sarah?
And one thing I would just add to that question, which this idea of sort of policies up here versus what's happening on the ground, is so few kids order off the children's menu. And so if they're not ordering off the children's menu, then what are things that can happen on the regular menu that can steer them away from sugary drinks?
Really good point. Absolutely. Okay, this question feels like it could go back to panel 1, but we'll see if you all want to answer it. If not, maybe we'll have someone from panel 1 talk about it, or even panel 2. So, seeking clarification on 100% juice. What proportion of 0 to 5-year-olds are consuming orange juice versus a kind of stripped down juice like grape, apple, pear juice, kind of a mixture that we know is lower in nutrient quality but still qualifies as a juice? So one might argue that an orange juice, 100%, has a lot of nutrients in it. We might all consider that 100% juice that we're comfortable with versus some of the more stripped down juices that are similar to sugar sweetened beverages. So just wondering if anyone knows, when we talk about consumption of 100% juice, and we saw that this morning, within that category, do we have any detail on it?
Because in 2008, when we published off of the FITS data, it showed the top sources.
Uh-huh.
I'm sorry. So I was going to say the data exists. So you can go into NHANES and actually look to see what particular food codes are contributing to the 100% fruit juice consumption. We haven't dived into that because, quite frankly, from a nutritional point of view, 100% fruit juice is, whether it's orange juice or apple or grape juice, it's pretty similar, with perhaps some of the natural sugars being slightly different. But in terms of what they're providing, I wouldn't necessarily want to go into one being much better than the other. I also know that in the FITS data, we actually looked at that a little bit, and it usually comes into play with, you have it right there? Yeah, Mary. No, I mean, it can be looked at, in other words.
No, I have it right here in the paper that we're submitting, but any fruit juice, let's see, this is for children 24 to 48 months, okay. So 2 and 3-year-olds. 45% had juice on the day of the survey. 21% it was apple juice, which again does not contain many nutrients at all. 7% grape juice, and only 16% citrus.
Great, thank you. I think it's a really important question and an important point. We all know the devil's in the details when you get down to the level of a category and the subcategories within it. So thank you for, I didn't know Mary had it, but I should have known. Okay, Kim, wondering if you could share any information about the new initiative, Healthy Beverage Zone in the Bronx, and its potential as a national strategy.
Sure. So the Healthy Beverage Zone is a relatively new initiative, and it is a collective impact model, or part of a collective impact model. So we have local level offices that are part of the health department. They're called neighborhood action centers, and we have one that's based in the Bronx, and they are part of a broader coalition called Not 62, and it's based on really coming together to raise the health status of Bronx residents. And so some of the work coming out of that coalition includes this Healthy Beverage Zone effort, and it has a whole host of ways that organizations can participate. They can essentially opt into various types of healthy beverage promoting activities, whether it's adopting organizational policy or promoting water. And I think that it is a really nice, we've had discussion about community engagement, and there's some references to the importance of the collective impact model. A California Endowment mentioned it this morning. And so I think it's an exciting work. It's not work that is led out of my bureau, so I can't speak to it in as much detail as I would like to, but I'm happy to follow up and answer additional questions about that.
Great, thank you. Okay. Sarah, we know that SNAP is a program that is directly related to what we heard this morning, and that is that most sugar-sweetened beverages are consumed in the home. So when we look at overall in children 0 to 5, they can get them in a variety of places. The majority is in the home. What other ways or what other federal programs, perhaps, of course WIC, but you're not allowed to buy them with WIC, could touch on the home and help us at a very early age to reduce bringing them into the home and therefore consuming them in the home?
Yeah, that's a great question. So the 7... Oh, thank you. So of the 7 programs that touch children at the federal level, SNAP is really the one that's going to allow sugary beverages to come into the home. Everything else is going to be in some sort of child care school setting somewhere else, or it's a prescription like WIC. So what do you do with SNAP? What's being debated hotly for quite a while, and this isn't a new question, is this notion that's come up already is, do you restrict purchases of sugary beverages within the SNAP program? And it has such strong opinions on both sides. I think if you ask me my personal opinion of sort of how you move the conversation forward, I think there needs to be some empirical data which says what actually happens in SNAP when you restrict purchases of SSBs, which would require the authorization of a pilot. And I think that's sort of the best way to continue the conversation in an objective way, because there's fact and there's fiction on both sides of that argument. And I suspect that with the authorization of the 2018 Farm Bill, that this conversation will become increasingly high profile. And so it'll be really interesting to see how it plays out. And a huge challenge is you have many competing voices who all care about helping low-income people, but don't sit on the same side of the issue. And because of that, I think it makes it hard to have forward progress from a public health perspective.
Yeah, absolutely. And pilots looking at incentivizing the purchase of healthy beverages akin to the fruit and vegetable program that's happened. I know those have been proposed and we haven't seen data yet, but it's another alternative that either could go along with restriction or could be different than restriction. But agree, we need the experimental evidence. And we have one more question. And I'll start with you, Heidi, but Sarah, maybe in your research you found something on this, or anyone else is welcome to weigh in. Do you see federal money supporting childhood obesity programs in FY 2018? Is it being seen as a priority, and in particular, anything new at CDC?
So we will continue to support childhood obesity programming through the areas I talked about, breastfeeding, childcare. We don't know what the future holds related to 18. We have been having some discussions with the higher levels within the Department of Health and Human Services. Dr. Price is definitely interested in childhood obesity. So I guess more to come. For us, we want to continue to have our surveillance systems. I took a lot of notes this morning about, areas that we need to improve, over sampling within NHANES, some of these childcare surveillance. So definitely our division, wants to support this area. So it's kind of out of our hands at the moment, if you know how funding comes to federal agencies. But as long as we're around, we'll continue to support this area.
And I would say that of the 7 programs that I touched on, that probably the best bet when it comes to thinking about where money would come from is probably SNAP-Ed. So SNAP has got a really, really big budget, $76 billion a year. SNAP-Ed is $400 million of that, but there was an explicit focus that's been increased around obesity prevention, and sort of opportunities to use those dollars in meaningful ways to help families in the program is, I would suspect, one of the better vehicles for opportunity.
Great. Okay, and with 12 seconds to spare, I want to thank Sarah, Heidi, Natasha, and Kim. This was a terrific panel. You covered a lot of ground, and I'm sure the audience is really appreciative. Thank you very much.